I think it's very easy to mention about DJD in patients younger than 50 years. And I think it looks simple. It's very easy to execute your surgery, but to give them results and to monitor them is critical. And the responsibility and the onus lies on the surgeon to take it through for as long as possible. So it's not an easy problem, really speaking, and minor errors can get augmented over a few years and lead to a major problem in later life. Most of these are recurrence due to cartilage injuries and poor anchor placements, chondrolysis. We've seen a few AVNs and infections, and I think that last group is far more challenging rather than the primary osteoarthritis, which is not so common in India in the young age group. We should not forget about rehab because that's an important part of treatment which can buy time, and arthroscopy as well, but I'll not delve into that. My biggest challenge is these guys are young, they are not as mature as the other patients, and they want to do sports and have an increasing workload. So before I start with my case, I just wanted to make a plea that have we laid the hemi to rest? A large part of Europe has given up on hemiarthroplasties completely, and I don't think so, because there's a select group of patients which will deserve hemi. This is a 18-year follow-up for a 65-year-old lady, and she incidentally came because she had a rotator cuff tear on the opposite right shoulder after she had a road traffic accident, and her left shoulder is still unharmed, and she's doing pretty well with 18 years on this hemiarthroplasty. I'm going to skip on the interposition part because I don't think there's much value in there right now, and not a whole lot of solid evidence. So coming to this 35-year-old lady who's had a pain for over a year, she doesn't remember any problems she's had with the shoulder, and this is an isolated monoarticular osteoarthritis, which I thought could be rheumatoid, but her blood markers were iffy. They were not clearly in favor of inflammatory markers. The MRI was pretty quiet. Luckily, the T1 SAT showed very good quality muscle, and that helps. And if they come in early when there's not much deformity on the head side, then I think it's a reasonable option to go ahead and do a repair on them, so do a stemless shoulder replacement. This is a French device made by a French company called Evolutis or Unique, which is largely popular in India. The whole thing is about balancing, really speaking, and to get the sizing right. Sizing is pretty complex because the base and the top need to be sized differently, so it has to be accurate. And I do a whole lot of intra-op imaging before I know that my trial is perfectly done, and the cuff has to be done in a proper parachute manner. If I can do that, then I know that these guys are going to come in with a good result, and we match the heads to their sizes. Now, this is our patient who's 35. She's 30 months follow-up right now. I'm hoping this video will play through. I'm not sure about that for some reason. But she's done well. She's 30 months. Our longest follow-up on the stemless has been 9 years and still well maintained. Apologies here. I don't know why this video wouldn't work, but she's a good result. Almost full range of movement. Her UCLA is about 32 out of 35. Challenges of technology there. Sorry, I'll just stop share and go back again. Allow me that. Sorry, guys. Okay, so is my screen showing?
No.
No. I'll just restart my share again. Okay, so we'll skip on that video. Yeah, so just to show you that this is a lady who is the 9-year follow-up. This is the older version. This is the cap from Depew. We've stopped using this now because purely it's not available. We've had great results on this, and even she's done well. She's 9 years, almost full range of movement, size well, no loosening yet. But this is the point I want to make. This is 2011 and this is 2019 now, and you can see that the glenoid vault is slowly getting medialized. Now, the biggest challenge is what do you do about that? Because the width is reducing progressively. She's completely asymptomatic and she has no problem. She has a full function. And at some point, she's going to come in for a revision, which is quite right. But when does one advise the revision? And progressively, it is going to start throwing out some wear material. And I'm hoping that the revision is not going to be too difficult with the stemless as opposed to a full-blown total shoulder replacement. These are a few articles about arthroscopy, very little on there. Most of them have a survival rate of about 2 years, 80%, and then they start deteriorating. This is an article from Peter Millett, who has a 85% survival at 2 years, and then most of them will end up getting converted into shoulder replacement. It's a great idea to buy some time. But the hemis, I think literature is not fair to them because there's a huge amount of loosening, especially 38% at 10 years from Walsh's unit, and then from John Sperling's unit. Although he had a 92% survivalship, 47% were unsatisfactory. So was there any point in doing a hemi on these? So my biggest concern is the hemis are getting a bad press, but we've had a good run with hemis. I don't have time to share all my hemi data. In a select person, when you think it's appropriate and the cuff is good, a well-done surgery will be fine. Luckily, with the stemlesses available now, I think our chances of doing the hemis are less likely. But we need a very, very close follow-up because these are going to come in for revision at some point. But the last point I would make before I close my presentation is what activity levels do you offer them? Because these are very young patients and they're very demanding, especially in my practice. So with the stemless, I'm a little liberal with them and I allow them to play table tennis and golf. And some of our hemis are also doing swimming activities. This is an article from Bill Malone, the editor from JCS. And he seems to suggest that the European surgeons are far more conservative than the US surgeons. Our US colleagues can opine on that. But certainly I'm loath to allow them to do any kind of contact sports or weightlifting and volleyball and basketball as such. So in conclusion, these are challenging patients. It's important to catch them early. I don't think there's a big deal to talk about here because these are younger patients. I find them much easier to rehabilitate. Giving them good results and full movements is not challenging. The challenge is in the future, what with the glenoid vault wear and what with the revisions. Short-term results, though, are good. In the long term, would they impact their reverse shoulders, or would you be doing total shoulders after a stemless, or would all of them be subjected to a reverse itself? Is a point that I would like to bring about for discussions. Thank you.